Mission and margin is the business of healthcare.
In this BOH episode, we explore how Carteret County, North Carolina, cut overdose deaths by 80% and overdose-related ER visits by 50%. Carteret County is a coastal North Carolina community of approximately 70,000 residents. Their population swells to 200,000 during the summer beach season. Carteret had a big overdose problem, ranked in the worst quintile in North Carolina. That's where Dr. Randall Williams and Brooke Lane come in. Dr. Randall Williams is the Consolidated Health and Human Services Director for Carteret County. He was Deputy Secretary of the North Carolina Department of Health and Human Services and State Health Director serving under Governor Pat McCrory. Brooke Lane manages Carteret's post-overdose response team, or PORT team. PORT teams respond when an overdose is detected, such as through EMS, hospital ED, and other referral sources. PORT teams are often made up of peer support specialists, individuals with lived experience in recovery, as well as community paramedics. The team goal is to detect individuals in the golden window when they are receptive to making a change. The peer support specialist then engages the affected individual to help them find the recovery path which works best for them. PORT teams, unlike ambulances, have a relationship with their participants for weeks, months, or even years. Goldie is a life-saving overdose detection and case management platform used by PORT teams. This BOH episode was supported by the North Carolina Medical Society, Project VBOT, and Goldie Health.
Dr. Randall Williams, Brooke Lane, thank you so much for joining the business of healthcare today. Tell me about your role and responsibility.
Yeah, thank you for your interest. I started 3 years ago as Director of Consolidated Human Services, which is both social services and the health department, but it was quickly identified that the number one health issue in Carteret County was the opioid epidemic. We were having 39 people die, many of them young. And it was when I interviewed for the job, they told me that, the county being on the coast was very good at preparing for hurricanes, with Emergency Operations Center opening up and bringing in all the partners. And it saddened them that they did such a good job with hurricanes and might, hopefully not lose anybody. And yet we were losing 39 young people a year to opioids, and we couldn't match that kind of response. And the comment was made to me, I remember saying, why can't we do that like we do for hurricanes? Why can't we bring everybody together? So I'm a surgeon by training, and so the first thing when presented with a challenge or a problem is to take a history. So we had 50 different entities in Carteret County of 70,000 people, third largest county in North Carolina, a very big county, 1,300 square miles, to see what they were doing. And we had a lot of people doing different things. We had churches and nonprofits and treatment facilities and doctors, hospital. But they were all disjointed. They were all doing their one thing, and usually they thought that was the thing to do. And I remember harking back to when I was a surgeon and somebody would get diagnosed with breast cancer. And when you get diagnosed with breast cancer, it's obviously very overwhelming. 1 out of 8 women get diagnosed. But you have to see an oncologist, a plastic surgeon, a general surgeon, a radiation oncologist, and hospitals assign navigators to them so that you don't have to figure out where to go. The navigator says, look, I've got this for you. I'll get you to where you need to go. And so as I interviewed these 50 entities, it dawned on me that what we really needed was somebody to triage, that to meet people at the point of contact and then be skilled to get them to where they needed to go. So I started looking at other port teams in North Carolina because we had the benefit, there were about 40 going at that time. And we also had the Department of Justice opioid money. So we had, about $800,000 a year. In Carteret County had about $13 million over 18 years pledged to us, but the first year it was front loaded, it was about $800,000. So we had the money, we just needed to devise a plan. And I went and talked to a county that had been doing it, and their engagement rate was 5%. If you overdosed in that county, the chances of you engaging with the port team were 1 out of 20. Because what they were doing is that the EMS or the police would tell you about a week later, oh, by the way, we were at Walmart or somewhere a week ago and we had an overdose, and here's the name. Well, they were long gone. So it became very apparent to me that it had to be real time. It had to be at the moment of overdose or referral. So we talked with our county manager and our county commissioners, and we had this pool of money, about $800,000. And there were lots of different groups. Those 50 groups all thought, gosh, you know, give us each $10,000. And our county manager, who I think was very visionary, said, no, we want to get impact. And so we're going to put all of our money in this port team. So we hired 6 people, Brook to be the leader, 5 with peer support. It became very obvious that was incredibly important to have lived experience. And bought 5 vehicles, $500,000 a year, and set it up to be 24/7 in real time. And to me, the huge difference in the program, to go from 39 deaths, and 1 death's too many, but to go from 39 deaths 2 years ago to just 4 so far this year, and to cut our overdoses by 90% in 2 years, and to reduce our ER visits by 50% in 2 years. People always ask me, you know, gosh, you know, how did you do that? And I think the 2 things that I would attribute that to are the peer support, the lived experience, and responding 24/7, engaging. I just heard Brooke mention there was this misconception out there that we had heard, well, gosh, even Randall, if you make contact, 50% of the time they refuse to go to the hospital. They won't get in the ambulance. And so everybody says, see, they don't even want help. Well, what Brooke has shown is with a 90% engagement rate, it just meant they didn't want to go to the hospital. It didn't mean they didn't want to get housing or treatment or Suboxone or get into Narcotics Anonymous. All that statistic meant was they didn't want to go to the hospital. So we've shown that if you meet them where they are with somebody with lived experience, 90% of them will get to a better place, which has been just astounding to me. It really has.
How much has your past experience, you've had leadership roles in healthcare for your entire career, medical director or a director of public health in North Carolina, you had a leadership role in Missouri. How much did that experience help you as you took on this problem?
It helped me tremendously. I vividly recall when I was working with Governor McCrory, and we got past the Narcan, universal Narcan under my DEA number, that for the first time ever in the history of North Carolina since the 1840s or so. Anybody in North Carolina could get a prescription under one doctor's DEA number, which was mine. And back then, it thankfully has changed tremendously, but there was this tremendous worry that you were creating a moral hazard, that you were legitimizing drug use, and it was a big issue. But as I always tell people, we went before the legislature, and it went before 8 subcommittees in the Senate and the House. And in all 8 subcommittees, it never had a negative vote. It passed all committees unanimously, passed the Senate and the House unanimously, and the governor signed it. So there was really, to me, the art of the possible, that we estimate 1 out of 3 families in the United States have been directly affected by the opioid epidemic. Not their 4th cousin, but I'm talking brother, daughter, child, parent, nephew. I mean, very directly. And so we found that the experience was so universal that it was really kind of a very transformational thing. I can remember talking to the governor, and he said, I've just heard the statistic that more people are dying from overdoses than car accidents. How can that be? I said, well, Governor, it's true. And so it's just incredibly encouraging to me that in those about 10 years, we really have changed our thoughts on people who suffer from substance abuse, and really have destigmatized that to realize that they can be helped and we can help them, and that they won't help. So that's been incredibly rewarding.
Yeah. Brooke, you lead the team.
Yes, sir.
Tell me what that means. Tell me what that experience is like.
Yeah, so my position at Carteret County Health Department is the team supervisor, team manager. I supervise our 5 certified peer support specialists. I help with day-to-day activities, policy, procedure type of things. I do presentations, I do data analysis, and kind of take all of that together to show our leadership team and our community what the good work that the team has been doing. And I help kind of point our team in the direction to continue to do the good work that they are doing. I teach prevention in our local high schools as well. Another thing that we've worked very closely with our county public school systems to implement, and our PORT team is involved in that as well, with speaking to students, providing resources at the end of the 4-day classes. And yeah, so really just day-to-day activities for me.
When you think about the journey that you went on, one of the things that's made your team so successful is the real-time response. Talk a little bit about what that means.
Yeah, so on our post-overdose response team, we're able to have that real-time response. So that means that when an overdose call comes out, we have a peer support specialist that is responding. And when you're able to have that initial contact with somebody, even if that initial contact isn't, calling a detox facility or really necessarily doing any work per se, but it's really just introductions to that individual, it kind of gets the ball rolling. It starts there. And from there, we follow up with individuals for at least 3 months. But as long as they need it, we have, yesterday was our 2-year anniversary, and we have clients that we're still working with that we started working with the second week into the program. And so we'll work with individuals as long as they need it, but it really does help us be able to make contact with more individuals. We sit at about a 94% engagement rate because of that real-time response, and that is something that we wouldn't be able to say if we didn't have going out, meeting those people where they're at when the crisis is happening. Because the people also remember, when I needed help, this person was here. And that makes them more inclined to call if they do have another crisis, or it lets them know that there is somebody that they can call who's going to meet them for treatment or help navigate them to that treatment. It's like Dr. Williams said, we know that it's not that people don't want treatment, it's just that people don't always want to go to the hospital. They don't always want to go to the doctor's office or whatever it is, because of personal experiences, transportation barriers, other barriers in life that have led them to where they're at now as well. And we're able to kind of break through those by being able to just have that initial contact with them and let them know that there's somebody that's going to come to them and meet them where they're at.
And what's the journey like for the peer support specialist? What's that experience like that you've observed?
Yeah, so there's 2 ways that we can get engaged with an individual. One is going to be through those overdose calls that EMS sends out, but we also take referrals. Somebody in Carteret County does not have to overdose for us to provide them services or help. Because again, a lot of times we'd like to get to them and help them before they experience an overdose. And so we have one phone number that anyone could call. Someone gets in a car wreck, they're not trying to figure out, okay, am I in this community? Am I in that community? Is it county? They just call 911. And somebody on the other end gets who needs to help them there to help them. Okay. And so, as Dr. Williams was saying again at the beginning, we kind of wanted to create a 911 system, but for substance use disorder. And so we have one phone number in our community that our residents and visitors can call. And That number connects them to a peer support specialist that is on shift, and they will ask them where they're at, and they'll go out to them. Usually within 30 minutes or less, we are connected with that individual after they reach out for help. We have a great relationship with our hospital as well, which was something that we were able to establish pretty early on, and we were able to get a call from the case managers or the nurses or the doctors at the hospital. And if somebody came in there and was seeking detox or was seeking treatment or help or whatever it was, they could call us, and we were going to go to the hospital. We have a MOA with our hospital that allows us to go in there and provide services as well. And so our peer, however they are engaged with them, however they meet them, whether it's an overdose call or whether it's a referral, they always allow either our nurses, medical professionals, paramedics, law enforcement to do what they need to do. We stand back, and once we're called in, we proceed with asking that person what they want, what they need, not telling them what they need, not telling them what they should do next, but asking them what they think and letting them be involved in the process. When we first meet with somebody, they might not be interested in help, and that's okay. And we'll say, okay, well, here's my card, here's some Narcan if they ask for it, and I'm going to be back in a week just to check on you. But if you want me to come back before then, that's my number on that card. And in a week, we said we're going to be there this day. We're there. We're doing what we call kind of like just a wellness check. Because if they're still at that same place where they're not interested in help, again, we'll come and check on them again. But a lot of times when you make that initial interaction and they see that you've shown up that second, third time when you said you were going to, they're going to be more likely to open up. That rapport is going to start being built, and it's going to be, well, hey, I heard about this treatment. What do you know about this? Have you seen other people that have tried this? What did that look like? And then that opens an opportunity for dialogue and a real conversation with them that could lead to, well, let's make an appointment. Let's go see how this could work for you. But we never push anything on anybody that they're not open, willing to do, and it's always up to the client of what treatment options they're connected to.
What makes the difference between a good and a great peer support specialist?
Oh, wow. So I'd say a great peer support specialist is somebody that is able to use their own experience to make informed decisions, but not let their own experience be all that they base their decisions off of. Mm. That somebody that is open to all forms of treatment, somebody that's open to what that client is interested in, because this isn't the peer support specialist's recovery journey. This isn't what worked for them or whatever. It's what is going to work for this individual, and it's about them. So again, using our own experiences, but not letting them dictate the treatment and the care that somebody receives is very important and something that is extremely valuable in making a great peer support specialist. It's person-centered care. It's not like we're not driving the car. Our client is driving the car, but we're in the passenger seat with the instructions, and they're telling us where they want to go, and we're helping them get there. So, and just making sure that we allow our clients to make their own decisions, because at the end of the day, it's their life and it's their recovery.
When you think about your work in the schools, what sort of reaction do you get from students in the education process that you've undertaken?
Yeah, so working in the schools is actually how I started my time in Carteret County, and it's kind of grown from there. Students, we do surveys for all of our students at the beginning of the lessons and then at the last day. And we have about a 90% of students give us the feedback that they're less likely to misuse substances after receiving the class. And 87% or higher say that they have an adult that they feel confident in talking to if they were ever struggling with substance use or knew somebody that was. But the real thing, or the biggest thing, is that I am from Carteret County. I went to the schools that these students are going to. When I'm talking to them, we're able to talk about the same restaurants or the same beach access or whatever it is, and able to make a connection with those students that maybe somebody else wouldn't be able to. I'm able to be honest and share personal experiences with them, and they feel, usually at least by the end of the class, that they're able to be honest and share personal experiences with me. I always start the class with letting them know that this is a judgment-free zone, that I'm here for them to ask all the questions that they want to know. I do ask them to be respectful with their questions, of course, but I let them know that this isn't somebody that's, trying to get you in trouble, or you're going to be reported if you come and tell me this or that. Of course, as long as they're not going to harm themselves or somebody else. But that this is that time to ask those questions that maybe we've thought about asking our parents or a sibling or something, but we're scared to for whatever reason. I give them opportunity before the class starts and after the class to come and talk to me one-on-one if they don't feel comfortable asking asking in front of the whole class. And then on that last day, when we do those surveys, we have them all on paper still. And that's because I tell the students before I hand them out, if you have anything that you want to tell me or you want me to know or any feedback, please write it on the back of these papers. I'm the only one that sees it. And we get a lot of feedback from the students, a lot of thank yous, a lot of my sisters dealt with this, or my uncle passed away last year of an overdose, and this has really helped me understand what he was going through, and just kind of giving the students an opportunity and a space to talk about things that have kind of been, icky to talk about before or uncomfortable to talk about in other settings.
Yeah, makes sense. Carteret County was a Goldie pilot, the first customer of Goldie. And tell me a little bit about the experience that you've had with Goldie. How has it helped?
Yeah, so we've had a great time working with Goldie, implementing it, going through the whole data transfer on all that stuff. Goldie team's been great at helping us with that. But since we've implemented Goldie, our peers are able to use that to report all their information, note-taking, and all that stuff with our clients. It's been very user-friendly for our peers. The staff at Goldie has been great as well, with being a great resource, being able to call, ask questions, because again, when you're piloting something, it's going to take time to get everything seamless, and staff has been great throughout that process. It's been able to cut down probably 2 to 3 hours worth of note-taking time for our peers, and they're able to now take that time and spend it with clients and more out in our community and not behind the desk, making sure that they're properly documenting everything.
When you say 2 to 3 hours, meaning 2 to 3 hours per day per peer?
Per day per peer, yes.
It's a dramatic efficiency gain.
Yeah.
You have a variety of medication-assisted treatment resources in the county.
Yes.
What, you use VBOT.
Yes.
What does VBOT do that makes them valuable?
Yeah, so we're very fortunate in Carteret County that we have multiple resources when it comes to MAT. VBOT is one of the virtual options that we use alongside the 3 clinics that we have in the county in person. But VBOT has been helpful in that if it's somebody who can't get up and get to the clinic at 6 a.m., 7 a.m. every morning, because it conflicts with their job or transportation is a barrier or whatever it is. They're able to use VBOT virtually. They're able to engage with a counselor frequently. They're able to do everything that they would be able to do in a clinic setting, but not have to necessarily worry about that transportation barrier, missing work, and those different aspects that come with an in-person visit. And so again, it's really about the individual and what works best for them. If we have an individual that's working long hours, we are a hospitality-driven community, so we have a lot of our individuals in the community are working abnormal hours. They're not working a typical 8 to 5. And so it can be difficult to get up and get to the clinic in the morning, or it can be difficult to make an appointment within those regular hours because, again, especially in the summertime, it can be very, very busy. And so somebody who is full-time employed or has multiple sources of employment, it's been very beneficial for those clients.
Nice. Randall, you've built an amazing program, or led the building of an amazing. Yeah. When you think about the abatement funds, that was a key foundation, a key ingredient. What happens in the future? The abatement funds are going to run out.
Well, they are, go out 18 years. They are front loaded, so they will diminish. As we always say, we'd love to work our way out of a job. But, again, it's been incredibly gratifying to start it, but, Brooke and the peers have clearly taken it over and done just amazing work with it. My vision is that it will continue to evolve. It'll get better. I mean, just look at what Goldie's done, reducing the amount of time by 3 hours, so it'll become more efficient. We spend a lot of time talking around the state about this because people kind of go, good gosh, you've cut your overdoses by 90%, your deaths by 80%. Tell us more about that. And so we certainly see part of our mission. We learned from other people. I think we were like the 45th port team. So we clearly feel like we have a role to tell people kind of lessons learned about that. But I think that if I looked at it, I think it costs us $500,000 a year to do it. And I think we have that built in for about 15 years. There's a county commissioner who I respect tremendously. He's been on a commission for 12 years. And when Brook presented last week, he said in his 12 years of all the things he had done, think a meeting every month, and they have a consent agenda of 70 things. He said for 12 years, 70 things every month, the most gratifying thing he's ever done was funding port. So my sense is that if for whatever reason 15 years from now we're down to less than 500,000, the county commissioners would readily pick up the funding. I think it's had that kind of import in the county. As I started off by saying, if we had 39 people drowning off the coast of Carteret County, we'd figure it out. Or if we had 39 people dying at the train intersection, we have a train that runs right down the middle of town, we'd figure it out. And so I think it was very frustrating to them because they really cared tremendously. These were nephews and friends of families who were dying, that we just couldn't figure that out. But through a combination of things, we're certainly not the only reason, in 2 years, it's just dramatically improved. And again, I give a tremendous amount of credit to the people with lived experience, having the willingness, because as you know, it's a trigger for them to relive as they're talking to people how come they have lived experience. So Brooke is incredibly sensitive to that and has built into her program to make sure they get self-care and that she's watching to make sure that they're okay. Because, I mean, you and I might be able to imagine that if we'd been struck by lightning, to go talk to people about being struck by lightning all the time would bring back a lot of memories. And so she's very, very sensitive to that, which we appreciate. But I still think there's room for us to grow and get better, and also to share what we've learned. So I'm just thankful that we kind of figured out something that helps. Because, like I said, 1 out of 3 families in America are affected by this. And if you go back to the history of drug use in this country, back to the 60s and the 50s, you know, and you can march it out, you know, between, you know, heroin and then crack cocaine and then meth and then prescription drugs and then, you know, fentanyl and now xylazine. Sadly, it tends to be a problem that just adapts, that when you kind of get a handle on one aspect of substance use, it moves into something else. But I think the principles that Brooke is putting into play, whatever comes down the pike, I think we can use these same lessons learned and mechanisms. So I'm thankful for that. But would clearly love to work our way out of a job. That would be fine.
Yeah. Well, Dr. Randall Williams, Brooke Lane, thank you so much for your story, and thank you for the work that you've done.
Thanks for your help.
Watch, listen, or read Business of Healthcare interviews at BOHseries.com.